Hello, I'm Heather McArthur. I'm the Medical Director of Breast Oncology at Cedars Sinai Medical Center in Los Angeles. It is currently Breast Cancer Awareness Month, the month of October, and we are live today talking to you about issues related to breast cancer. It's a particularly exciting time for the field of cancer in general. As many of you may have noted, two physicians were awarded the Nobel Prize recently for the successful identification of key mechanisms that have allowed for successful drug development that boosts the immune system. And if you can boost the immune system and focus that immune response to cancer, then you could develop a long-term tumor-specific immunity. So that's the science that this incredible promising strategies are built on, and it's wonderful to see that they were awarded the Nobel Prize. And in fact, in the coming week, we are going to hear news of the first immune therapy trial in breast cancer that was conducted, a large global effort randomizing women with metastatic triple-negative breast cancer who've not previously been treated to gold standard of care chemotherapy, or that same gold standard of chemotherapy with one of these modern immune therapy strategies. And so this is a positive study. We're anxiously awaiting all the details of that study, but it's an incredibly optimistic time for breast cancer in general, as this opens up a whole new field of potential opportunity for us.
Okay, so we'll get started with our first question. Laura would like to know, I'm 64, at what age can I stop getting mammograms?
So the question is, and thank you, Laura, for writing in, the question is, at what age can I stop getting mammograms? And Laura says that she's 64. So that's actually a really interesting question, and there's some recent data indicated that there's no upper age limit at which we should stop receiving mammograms, and really those decisions should be made on an individual basis. As we're all aware, there are 64-year-olds who are incredibly healthy and have decades of life ahead, and those people are people in whom you would reasonably consider continuing mammograms. And of course, there are the 64-year-olds who aren't as healthy, and in that setting, mammograms every year may no longer be appropriate. There's also some discussion around what's the optimal frequency of mammograms, whether you can do your mammogram every other year. However, most of us still apply the standard of yearly mammograms. I hope that helps, Laura.
The next question is, are there foods I can be eating that will lower my risk of breast cancer?
So the question that I just received is, are there foods that I can be eating that can lower the risk of developing breast cancer? And I guess that same question would apply to people who have had a diagnosis of breast cancer and are looking to reduce their risk of recurrence. So it's a really interesting question, and in fact, billions of dollars have been spent trying to understand the impact of diet on breast cancer risk. We have interrogated Asian versus Mediterranean versus North American diets, for example, and the bottom line is that there is no clear specific diet that reduces risk. My personal mantra is one for balance. So an apple a day is probably a healthy choice, whereas 100 apples a day would probably make you sick. So I think balance in all things, including diet, is critically important. There is, however, increasing data that exercise can prevent breast cancer recurrence and occurrence, and that exercise can prevent other cancers from occurring. Furthermore, keeping your weight down, so keeping your weight within a body mass index of 20 to 25 has also been associated with reduced breast cancer risk. So healthy eating, diet, exercise, and keeping a healthy body mass index are all ways that you can reduce your risk.
Carrie would like to know, opposite of Laura's question, what age should women start getting mammograms?
So the question is, at what age should we start to get mammograms? And so women who are at normal risk should start to get mammograms at 40. Again, there's been some debate about whether 50 is an appropriate age to start mammograms, but in North America, we typically start at age 40. The exception to that rule would be for someone who is at higher than normal risk. So in patients who have what we call a BRCA mutation or who have a strong family history of breast cancer, those people might qualify for earlier screening, typically age 25 or 10 years younger than the affected individual. So if your mother was diagnosed with breast cancer at 33, you would qualify for screening at 23, so 10 years later than the affected individual, or age 25, whichever comes first. Notably, younger women who are at higher risk of developing breast cancer, again with a family history with a BRCA mutation or a prior significant biopsy, those women are often also considered for MRI breast screening in addition to mammography.
How often should I be doing self-exams?
So the question is around self-examination, and there is a lot of controversy around self-examination. It has not been shown to increase detection of breast cancer. However, I think body awareness is generally healthy, and monthly self-examination is probably a healthy practice.
Nancy would like to know, can we talk about whether underwire bras are okay to wear?
So we have a question regarding bra type and whether underwire bras or wireless bras are preferred, and there's no data to indicate whether there would be any concern with bras that contain wires.
Nancy would also like to know if antiperspirants that contain aluminum are okay to use.
Okay, so the question is around antiperspirants, and specifically antiperspirants that contain aluminum or deodorants that contain aluminum. This is another area of controversy. There have been some studies that have suggested that there may be an increased association with breast cancer, not necessarily risk, but association. However, that data has not been very consistent or compelling, and what I struggle with is if that were true, then we should see a higher rate of bilateral breast cancers or breast cancers affecting both breasts because the deodorant or antiperspirant is being applied to both sides, and we have not seen an increase in the incidence of bilateral breast cancer. So although I admit that there's some evidence to the contrary, I don't think that there's any clear indication that that poses a significant or real risk.
Judy would like to know, should women be concerned about dense breast tissue?
So the question is about whether women should be concerned if they have dense breast tissue. A lot of women have dense breast tissue, and in fact, the hallmark of young women is dense breast tissue, and usually that density decreases over time as we age. Density makes detecting breast cancers potentially more challenging on imaging. And if you have dense breasts when you go for your mammogram, the radiologist might ask to do one of two things, might ask to get additional images on mammography, to get different views to overcome that density, or apply different techniques like ultrasound.
Is there any truth about the way mammograms are done that could be bad for you?
The question is whether the method by which mammograms are done could be harmful. I think that the question embedded there is maybe around the radiation exposure to breast, the breast, if I understand that question correctly. And the dose of radiation to the breast is extremely low. And of course, mammography is the best tool that we have available to increase the detection of breast cancer. And in fact, breast cancer detection rates have gone up for a few different reasons. Number one is improvements in technology, and another is improvement in public education. So detecting smaller breast cancers earlier on because women are adhering to breast cancer surveillance with mammography.
What's your advice for someone newly diagnosed with breast cancer?
So the question is, what's my advice for someone newly diagnosed with breast cancer? And my advice is to get information from reliable sources. It's very overwhelming to face a new diagnosis of breast cancer, and there's so much information on the internet, and not all of it is always helpful. So I think that getting information from respected physicians, often an opinion is sought from a surgeon, a medical oncologist like myself, and sometimes even a radiation oncologist. If there's any question about my recommendation, I always encourage people to get second or third opinions. I think it's really important to be totally confident as you go down your treatment path, that you have complete confidence in the steps lined up ahead for you. So I think that's really important to get as many opinions as you need. There are also a lot of great resources on the internet. The American Cancer Society has an excellent website with really great data-driven information on breast cancer. And Susan G. Komen also has a great website. So that is a grassroots survivorship-based organization, and they have terrific information as well. So I think getting information from respected physicians and from respected internet sources, and of course from other people who have experienced or lived through breast cancer can be very helpful, and we have a number of survivorship groups that often people find very helpful.
Laura would like to know if there's anything exciting on the horizon in terms of how we screen for breast cancer.
So the question is around screening for breast cancer, and are there any new techniques? I think it's a really exciting area of investigation. There are advancements in mammography. Some of you may have had 3D tomosynthesis mammography, and there is a lot of interest in that particular technique. As a strategy, there are markers that are used. So whenever you've gone for a PET scan or CT scan, often they inject a dye or a marker that's traceable. And so there's a lot of interest in identifying markers that are specific to certain breast cancer features. So I think that's a really exciting area of investigation. The other areas that I think are really interesting are blood tests to detect for metastases or spread of cancer. So currently, when we screen someone with early stage disease for metastases, we usually use some sort of imaging like a CT scan or a PET scan. But tumors outside of the breast, so in the liver or lung, when they've spread, have to grow up to a certain size to be visualized on a PET scan or a CT scan. And what we're really curious about is who has micrometastatic disease, or who has a handful of cells that have escaped from the breast and are waiting to cause problems in the liver or lung, for example. But right now in 2018, we can't see them with our modern imaging. So there's a lot of interest in doing specific blood tests where we look for things like circulating tumor cells. So if you can identify the one cell that got away that's circulating in the body, that could be incredibly helpful information. Or even cell-free DNA, where the tumor itself, the cells have actually broken down, and you're just looking for the DNA that was in the core of those cells. So I think there are a lot of really, really interesting techniques being evaluated both in the lab and radiographically, not only for the detection of early stage breast cancer, but also to improve early detection of metastatic breast cancer.
Elise would like to know, if my paternal grandmother died from breast cancer, does that mean I may get breast cancer?
So someone is asking a question about family history and risk for genetic breast cancer. Typically, increased risk for a genetic mutation that you're born with that would predispose to developing breast cancer might be having a first-degree relative. So that example that I gave earlier, where there was a mother that was diagnosed with breast cancer, having 2 or more second-degree relatives with breast cancer, so having multiple relatives with breast cancer, having a history of male breast cancer in the family, having a compelling family history of breast cancer where people are affected at a young age. So typically, an affected individual, like a mother diagnosed at age 80, wouldn't indicate that there's a hereditary risk for developing breast cancer. So it's typically having multiple family members who are diagnosed at a young age, and or a family history of male breast cancer, or women with Ashkenazi Jewish ancestry have a higher incidence of breast cancer.
Have you read anything about vitamin D testing being a better indicator of breast cancer than mammograms?
So the question is around vitamin D testing as an indicator of breast cancer, and the question also ties in the use of mammograms. Mammograms are still the best tool that we have available for screening for breast cancer, so that's still the gold standard. There's considerable interest in the relationship between vitamin D and breast cancer. There are some that believe that high doses of vitamin D supplementation are important for preventing cancers from occurring, not just breast cancer, but other cancers as well. Although the data around what dose of supplementation is ideal is still not clear. But as yet, vitamin D levels are not used to detect for new breast cancer diagnoses.
Beth would like to know if there are different levels of dense breast tissue.
So the question is around density, and there can be different degrees of density, and it may there's also individualized reasons like size of breast that might make breast density relevant in one person more than another person. There's currently no standardization of density that's reported on the mammograms. It's typically a comment, and it might not be homogeneous. There might be different areas that are more dense than others. So there's a lot of individuality in the comment around density.
Do you have an opinion around thermography as a screening technique?
So the question is around thermography and whether it can be used to screen for breast cancer. I think it comes under the heading of really exciting concepts that are being explored for the detection of breast cancer. As I said, mammogram is still the gold standard for early detection of new diagnoses, but I think that applying things like evaluation of heat patterns, that's what thermography does, is looks for temperature differences with the idea that cancers have more blood flow and therefore may be more easily identified, are really exciting, and I think that the field will change dramatically in the coming years as we start to better understand who would benefit from these kinds of strategies.
Is there a link between oral contraceptives and breast cancer?
The question is about risk factors for breast cancer. There are numerous risk factors for breast cancer, including birth control pill use and duration of use, hormone replacement therapy, whether you have had a successful term pregnancy, what your age was at pregnancy, the age when you first started having menstrual periods. Obviously, that's not something that any of us can control, or your last age of menstrual periods, and of course the genetic issues potentially that some people have where they've inherited genetic predisposition for developing breast cancer.
What's your advice for somebody approaching their first mammogram?
My advice to someone approaching their first mammogram is first to say congratulations for being on top of your routine health maintenance. It's such an important issue, and in the United States alone, more than 250,000 new breast cancer diagnoses are made in each and every year. So 250,000 women are going to be diagnosed with breast cancer this year. And so mammography, as we said earlier, is really important to identify breast cancers early when they're small and more amenable to cure. So I would say, first of all, congratulations. I'd say, second of all, be prepared for some discomfort. So if you're familiar with the technique, what's done is that the breast is placed on a pad and squeezed between two pads, and then pictures are taken. So there can be some discomfort. And then also not to be afraid if additional images are requested. So what will happen is often after you have completed your standard mammogram, that you'll be asked to wait in a waiting area while the radiologist reviews the images and decides whether additional images are needed. If you are being asked to come back for additional images, it's not necessarily because anything's wrong. In fact, it's often a function of what we talked about earlier, which is density of breasts and the desire to get better or additional images. So congratulations, be prepared for potentially some discomfort, and don't panic if you're asked to provide additional images. It's usually just to be on the safe side.
And we'll take the last question. Is there any correlation between breast size and cancer risk?
So this is the last question, and thank you all for joining us today. The question is around breast size and whether breast size predisposes for breast cancer risk. And there is not any compelling data that there's a relationship between breast size and breast risk, although those are very difficult studies to do potentially, because breast size could be a function of overall body habitus. And so there could be a number of confounding factors that would make it difficult to interpret that kind of data. But at this time, there is currently no indication that increased breast size increases the risk of breast cancer. And that's all the time we have for today. Thank you again, everyone, for joining us. It's been terrific. And thank you for helping us to celebrate Breast Cancer Awareness Month. And go out and get your mammograms. Thank you.